Good afternoon, everyone. I'm sorry I'm a little bit late. So I was asked to come and talk to you today about what happens, what's the physiology behind what happens in labour and birth of your baby. So very much, I think we've touched on this a little bit in some of our other films, but what we wanted to talk about, what happens, what's that preparation that happens when you're having your baby, and what's happening to your body. So I'm going to talk about normal labour and birth. I'm going to talk about, a term pregnancy, because obviously if you're having any contractions or pain and your pregnancy is less than 37 weeks, then it's really important that you don't delay getting advice from a midwife phoning the maternity assessment unit, because we want pregnancies ultimately to go beyond 37 weeks. So what I'm going to do today is I gather there's lots of questions and things that people may have about other things that are going on. And so what I'm going to do is talk about the physiology of birth for about, 15, 20 minutes, half an hour, as long as it takes. And I'll take any of your questions to begin with about physiology of birth. And then after we've had a chance to talk about that, then we'll talk about some of the current issues that you may have, and hopefully answer your concerns. So if you ask a question that's not about physiology of birth, I hope you won't mind if I don't answer it during this session, and then we'll progress to it afterwards. So good afternoon to you too, Melissa. So on we go. So what I wanted to talk about today are the various stages that we have in labour. So when you talk about it to anybody about labour, they'll talk about the first stage of labour, the second stage of labour, and the third stage of labour. We also believe quite strongly in the fourth stage of labour in Oxford, and I'm going to talk about that as well. So in terms of what happens, people quite often say, well, what's going to happen first? Am I going to contract, or my water's going to break? What's the significance of my show? So if we just talk about the physiology of what's happening in your uterus, your uterus is growing beautifully during the pregnancy. The muscles are expanding to create this space for your baby to fill. And what happens when you go into labour is that those muscles have to start shortening. And what they're doing is they're shortening to reduce the space, and they're giving the baby that push down, so that baby's going down into your pelvis, and then will hopefully be born. So the reason that you get these contractions are because the muscles are shortening. So they're going from being these long muscles and they're shortening down. And you have your uterus is like, it looks like a balloon, I suppose, that's like that. And then on the bottom you have the cervix. So the cervix is the thing that you will feel if you were to insert a finger digitally into your vagina. You would be able to feel your cervix. Now, we don't recommend that you do this, especially not if you're under 37 weeks pregnant, but it is about what that cervix feels like. Now, when you've never had a baby before, that cervix is sort of 2 to 4 centimetres long. It's hard like the end of your nose, and generally it's closed. It's like a closed tube, or it might be like a fingertip, so slightly dimpled. And it has an external opening. So imagine this is a cylinder. It has the external opening that is towards your vagina, and it has the internal opening, the internal os we call it, which is joined onto that balloon that is your uterus. So what happens in labour is that the muscle fibres shorten, and what they're doing is they're pulling the cervix open. And I use all sorts of silly analogies, but my common one for this is a skinny rib polo neck. If you have a polo neck and you're trying to get it over the top of your head, so imagine this is the cervix or the neck of the polo neck, as you are pulling the jumper down onto your head, you can see that this bit is starting to shorten, which is the cervix, and it may open up a little bit before you get to the point that your head can come through. So the same thing applies to the uterus. It is this balloon, and what it's doing is it's pulling the cervix out and round the way away from baby's head. And it does that in response to baby's head is pushing on the cervix. With each contraction, the baby's head, and I have a baby here to show me, we have to use my imaginative cervix. So as baby is in the uterus and baby's head is coming down, with each contraction, with the pressure, it's causing that cervix to move out the way and to move out the way of baby. So baby descends into the pelvis and the cervix, hope you like my baby's pink baby glow, hold on to baby. As the baby's head is coming down, the cervix is moving out the way to enable baby to progress down. Now, the opening of the cervix, like I said, is like that polar neck being pulled around baby's head. So the first stage of labour is from where that cervix is completely closed to where that cervix is starting to open up. So we have two phases of the first stage of labour. We have what we call as a latent phase of labour, and then we have the second stage, which is the active first stage of labour. So the latent phase of labour is characterised by irregular contractions. So you'll get some contractions and they'll be really strong and really painful and quite long, but then the next contraction might be quite quick, won't be as strong, may not last as long. Or you may get a couple together that are really strong, but then you get a big pause before the next one comes. So this irregularity of contractions, one being stronger than other, one lasting longer than other, you know, how long they last for, how they're felt by you, that irregular pattern is very common in the latent phase of labour. And we call it the warm-up. It's trying to shorten and soften that cervix. And so it's taking that 2 to 4 centimetre cervix that's hard down to 4 centimetres dilated, nice and thin and soft and squishy like your lips. So all that length will be gone and the cervix will be about 4 centimetres dilated. Now people talk about the magic 4 centimetres dilated and you know, it's only one part of the equation. And you don't need to know that the cervix is 4 centimetres dilated as well, in terms of for you to say that labour is establishing. So, you know, vaginal examinations are part of the assessment, but only a small part of the assessment. A lot of the assessment involves the midwife spending time with you and she's feeling your tummy. Now, she will feel the top of your tummy, the bump, she says, and I stand up. So the bump of your tummy up here is where the midwife will put her hand because she will feel the contractions best there. Because contractions have what we call fundal dominance, which means they're starting at the top. That's where the muscles are shortening. But for you as a woman, you may feel it anywhere else other than the top. So you may feel it down underneath your bump. You may feel it in your hips, and some women, about 30% of women, feel it in their back. So the actual contractions that you're feeling are very much, we feel it by feeling how they're presenting, by feeling your abdomen, but you will feel it depending on the nerve endings in different places. So that latent phase of labour, that irregularity that happens, like I said, is the warm-up. And what you might find is that it comes for a few hours. Quite often it's not very clever and happens at night, so you have a disturbed night's sleep. But then it may all go away again and not come back perhaps till the following day or half a day later. And it will always come back. It's just that it's your body's way of doing a bit of the preparation work and then giving you a rest to relax and recover. Now, how you cope with that in the first stage of labour is very much about listening to your body. If you're really tired and you lie down and the contractions go away, then absolutely you should sleep, if you can sleep. And even if you lie down and you get a break in your contractions and you can doze in between them, that's amazing because that helps your body to recover. And the reason some people don't stay lying down is because you might have gone almost 2 weeks past your due date, you're desperate for your baby to come, and actually when you're up and walking about, the contractions feel much stronger, but when you lie down, they go away. And so people think, oh, I must get up because my contractions were better when I was mobilising. but actually you don't give your body time to recover. And therefore it does mean that you can end up being exhausted and your muscles tire, just like any muscles do if you're doing a lot of exercise. So my biggest bit of advice is, if you're in labour and you lie down and you can go to sleep, amazing. Sleep, catch up, and go from there. The other things that are really important to do, which you don't feel like doing when you're in labour and you're having contractions, is you don't drink very much, you don't eat very much, and some people are quite sick with the pain. And what happens then is your body doesn't have enough energy reserves to keep going. So the muscles then may still contract, but not at the same intensity. So we do say to people, please eat little and often, drink little and often, make sure you're going to the toilet to pass urine. All of those things are really important, because the kind of energy you use in labour is a bit like running a marathon. And if you know anybody that's done intensive exercise like marathon running, you would never run your marathon, or not run it very well, if you hadn't eaten, slept, drunk, and you've been vomiting for 24 hours beforehand. So it is about you being in the peak physical condition. And that's why we say to women, you must, especially towards the end of your pregnancy, balance your exercise with rest, because it is important. Get used to catnapping during the day, if you can, if you don't have other children running about disturbing you. But it is important to try and balance that exercise and rest. We want you to stay as fit as you can. So even when you're in lockdown and they're saying don't go very far, having your daily exercise, your daily walk is brilliant, because again, it's just about keeping yourself in good physical condition. So I'm doing more, talking about coping mechanisms of labour rather than the physiology behind it. So in that latent phase of labour, the place that is the best place for you to be, now remember this is for normal low-risk women, is at home. Because at home, there is more to divert your attention. You can read, you can sleep, you can eat what you want when you want, you can watch films, you can do whatever it is, get into your hypnobirthing zone without having the disruptions that can happen in a hospital. And we find that women do much better being at home in those early stages. I mean, it's okay, because people are always frightened. I think more so probably birth partners. Is this it? Am I going to have time? I don't want you to have a baby at home. Quick, let's go to hospital. But actually, if you're confident in yourself and think, do you know what? Everything's okay. My baby was moving all right. I'm feeling good. They're still irregular. And you might have one and 2 minutes later you have another one. But if it's 6 or 7 minutes until you have another one, then it's just too early. We need a little bit more time and for them to build and become regular. And in terms of the cervix, like I said, it's just going to slowly, that first few stages is going to slowly pull that cervix down and shorten it round a baby's head. And once it's got to the point that it's nice and thin and it's soft and squishy, that bit happens much quicker. So if you know anybody who said to you, my labour was 4 or 5 days, the bit that they're taking into consideration is that latent phase of labour, that stop-start period of time that happened over a couple of days before they actually then had the midwife stay with them, either at home or be in a midwifery-led unit or the delivery suite. So when you go into established labour, that's when all that shortening has happened and the cervix then starts to move much quicker out the way. Now, if you look at a baby, I'm going to show you my lovely baby again. If you've ever handled a newborn baby, you will see that most of them tuck their chin down. And because they tuck their chin down, it's this small bit of baby's head, which is roughly about 9.5 centimetres in diameter, that sits on the cervix. And because it's nice and circular, I don't know if you can see, it forms a good seal. So each contraction that you have and the baby's putting pressure on the cervix causes pressure all the way around that circle, and so that as it's being pushed out the way, it's moving symmetrically. What happens sometimes, more so when you get tired, but babies, being the cheeky thing, they're the things that basically dictate how labour is going to go. Instead of tucking that chin down, what they do sometimes is straighten their head and they turn onto their side or round onto their back, and this head elongates. Now when it does that, instead of it being this nice smaller circle here, it becomes, this shape is more oval shape. So if you know anyone that's had a baby and you can see it, obviously with social distancing, you will see that it's more oval shaped, that bit of the head, compared to the circle at the back. And if it's oval shaped here, when the cervix is sitting there, there are some gaps, which probably not very easy to see, but there are some gaps because the cervix doesn't sit as well on it. So each contraction is applying pressure at different points. So it can be a little bit slower for that baby to push the cervix out the way. And it's not something you need to worry about. It's just that baby is making the turns and manoeuvres to get into the pelvis. So with these nice big contractions, baby's head will descend into the pelvis. Generally, now this pelvis is a bit dodgy. She says, I brought one to show you. I know you've seen it before. But generally, which way? That way. The baby is, the wider part of the cervix, of the pelvis, is this way. And it's narrower that way. So people always say, oh, I don't want my baby to be back to back. It is really common for your baby to go into the pelvis, side on or round in the back, because there's a lovely curve here. Now this baby won't fit in this pelvis, but if it did, where it is, you can see that it fits much easier if it's going inside on. If it was that way round, it hasn't quite got the same manoeuvrability to get in. It would go in, but it's much more comfortable for a baby to go that way. And I think what you'll find when you're pregnant is you will feel the back of your baby more on one side and the kicks and movements on the other. And that's completely common. Your baby is just finding its way into the pelvis to be born. So obviously your baby would be nice and curled up. It's going into the pelvis. And then what it should do is rotate forwards. And this is the bit I'm not sure will work. Oh, it does. And this is the bit, it is moving baby out the way. And I'm going to take it out the pelvis because I am holding on, I'm missing my bolt on the back of the pelvis. So I'm just going to show you how baby descends down. So imagine this baby is in my pelvis, it's moving down, side on into the pelvis. It's going to meet the resistance of my pelvic floor. So your pelvic floor is a hammock of muscles that sit between your legs, and it holds everything inside. So it holds onto your bladder, your vagina, your bowel. It's holding everything up inside. So when that baby comes down into your pelvis, it's pushing the cervix out the way. And when the cervix is out the way, it's making a turn round for it to be born. So like I said, the first stage of labour is taking you from that long, hard, closed cervix, and it's going to shorten, soften and open, and roughly around 4 centimetres dilated, that it'll be nice and thin. And then at that point, the labour will progress much quicker. And roughly we say, having your first baby, the cervix will progress more than, generally more, but at the slowest about 0.5 centimetre per hour. And if you're on your second and subsequent baby, we roughly quote 1 centimetre an hour. Now we meet lots of women having their first baby who came in at 4 centimetres and half an hour later or more, we have a baby. And we meet women having their second baby who again come in and birth their baby very quickly. Some people it takes a little bit longer, but it's just that baby negotiating. And we will be saying to you, you know, let's try some things, build your energy levels up. Have you had some breakfast this morning? Sometimes we feed women toast here when they come in because they haven't eaten all night. So it's about having those nice calorie loaded snacks to help you go. Think of people that run marathons. Bananas are excellent. I looked after a woman the other day and I said, what we could do with a banana, and she said we bought some but we left them at home. But you know, having bananas, flapjacks, bits of orange, jelly babies, things like that, having isotonic drinks that'll help keep your energy levels up and replace some of that energy that you're losing with the contractions. So like I said, progress can be quicker than that, but it will at least take you that period of time for your cervix to move completely out of the way. And when your cervix is moved completely out of the way for a baby to be born, that means the cervix has got to about 10 centimetres. And again, we won't always know that it has got to 10 centimetres because you might just start pushing your baby. So please don't think we're driven by doing vaginal examinations, because we do all sorts of different ways of assessing how you're progressing in labour. And it becomes very apparent to us. You make a change in noises, you make a change in how your body's responding. The contractions feel much more expulsive. And that's very difficult for me to describe to you. That comes with experience as a midwife of knowing those changes about what's happening in the room. It's quite common that we may see your anus start to open and gape. Now, sometimes you may pass poo at that time, and women are very embarrassed about that. But please note, we would be extremely discreet. But it's just, if you imagine that if I use 3 fingers, this one is the tube that comes out your bladder for when you pass urine. This one is your vagina, and this one is your back passage. What's occupying this one, the vagina, is this big head of babies. Promise not too big, just the right size. And it's coming down and it puts pressure on both. So sometimes women struggle to pass urine because the baby's head is pushing on that one. And sometimes they might pass a little bit of urine when they're pushing. Again, that's quite common. You have no control over it. It doesn't mean that you'll be incontinent afterwards. It's just that this head that is coming down is putting the pressure on it. And the same applies to the back passage. Quite often in preparation for the birth, the body's clever and you have a lot of evacuations in the 24 hours before to get rid of it. But if there is anything in there, you have no control over it. It has to come out. The baby will push it out. So the thing that we may know that you're having your baby is because that anus is dilating and we can see the baby's head moving down in your back, the fullness in your back, as baby's head is descending and coming down. Later on, as you're advanced in the second stage of labour, you quite often get this red line which runs up your buttock, which again can be another sign. So we're looking at all those different signs to tell us that basically your lower pelvis is full, baby's head is down there, and baby is ready to be born. So it's at that point with those nice big contractions that baby has to make some turns to be born. So as baby is here and coming down, she says, I'll hold on to it because most babies are, excuse me, I have a tickle. I think I just talked too much. As the baby's head comes down, do you remember I said it meets the resistance of your pelvic floor? And what happens is your baby should then rotate forwards. And it's rotating forwards to have its back uppermost, and it will fit then better into the pelvis for baby to be born. And by rotating round, it enables baby's shoulders to be in that nice long, so this doesn't fall apart. It enables baby's shoulders, told you it had a mind of its own, this pelvis, to make those shoulders be able to descend and come out of the pelvis. So baby has rotated round and its shoulders are now coming down. And what happens is you have your bone at the front of the pelvis here, she says. And what happens then is that your baby's head is then born in a movement by extension. So what it's doing is the baby is arching its head to come round, because what's here is your pelvic floor muscles, and baby is nicely stretching these muscles to enable its head to be born like that. Okay, so that's baby's head has come down. It's been nice and curled up. And then this hand that I've got here is your perineum as the baby comes and clips its head over. And it's made that movement to enable the shoulders to move down through the pelvis so that they can be born. And what happens is the same as the baby. The shoulders then meet the resistance of the pelvic floor and they turn for baby to be born. And then the shoulders are born in the same way. They sweep the perineum as baby's born, and then baby is born. and that's the end of the second stage of labour when your baby's born. And it's at this point that we hold the baby at the level of your tummy button, and we do, for all births, however baby's born, we do delayed cord clamping, because that enables the baby to get some of its blood volume that might be going backwards and forwards between you and the baby. And in that first 1 to 2 minutes after the birth, the baby gets its right amount of blood volume, which means that it has good iron stores for the first few years of its life. So we get you to cuddle baby. Now, some people choose for their babies to be dried and wrapped at that point. Some people just want baby straight onto their skin. But ultimately, however you're feeding your baby, we think it's really good for baby to stay skin to skin with you, because that helps regulate baby's heart rate, their breathing, their temperature, and helps with that initial bonding process. So skin to skin with mum at this time is ideal. If for some reason it's not possible, then we can, once we've cut the baby's cord, we haven't cut baby's cord at this point, but once baby's cord has been cut, baby can then go skin to skin with your birth partner if for some reason you don't feel that you can go skin to skin with your baby. So that's kind of the first bit. So imagine baby is stillborn. That's been the end of the second stage of labour. The cord is still attached for those first few minutes. Then we have to have your, the next bit is the third stage of labour, where that placenta, the membranes and the baby's cord, that have all been helping keep your baby alive and growing in pregnancy, have to come out. Now, there are two ways for that to happen. We can wait for nature to take its course, and that will then mean the placenta will come out anywhere between 5 minutes to an hour later. And if that happens, what happens is the contractions start again, because it's again, the space was evacuated by the baby, and the muscles can contract down much harder, and that then forces the placenta off the wall of the uterus, and it falls down into the vagina and is then born. So you still experience some contractions. They're generally not as strong as the contractions that you had for the baby, because once you've had those, you definitely want those to stop. But you do get some contractions again, but actually passing the placenta is much easier than the baby because it's all soft and squishy. And breastfeeding, if you're going to breastfeed, can help that speed that process up, because the contractions are all based on your natural oxytocin, which I should probably have talked about earlier, but the natural oxytocin that comes from feeding your baby helps with those contractions to help the placenta come out. The physiological birth, people like it if they haven't had any drugs in labour. The drugs don't actually pass into the baby, but they like it because they think, well, we'll just let nature take its course, there's no rush. There is an injection that we generally recommend for most women, because the injection speeds up the process. The injection can be in your leg or in your arm, and it basically it takes about 2 to 3 minutes for the injection to work, but it enables that crunch to help the placenta come down much quicker, and is associated with women losing less blood at the time that their baby's born. And the advantage to losing less blood is just that if you lose too much blood, it can affect the quality of your milk and the quality of you healing afterwards. So we want you and the baby in the best physical shape afterwards when you have your baby. So that's one of the reasons we recommend having that injection. So that then comes, what happens with the placenta is the placenta is attached to the wall of your uterus, and imagine this is the cord. The placenta comes off, falls down, the cord advances, and when we've given the injection, we basically give the cord a gentle pull to enable it to be born. So that's then the end of the third stage of labour, once the placenta membranes has come out. And the fourth stage of labour for us in Oxford is that key time, and I'm sure it happens in other organisations too. It's not just an Oxford concept, but it is about giving the time for the bonding to establish. So we try not to rush things like dressing your baby and feeding your baby. You know, breastfeeding is really important, as you know, if you choose to bottle feed, you know, equally, you know, baby will want some food, but it's about giving you that time and space and not rushing you through. Sometimes we have to intervene a little bit. We try to still keep baby skin to skin if possible, but if you have some stitches, or if you need some stitches and it's bleeding, we might have to disrupt things a bit to try and get that right to minimise your blood loss. So we might intervene a bit then, but we try not to rush you and move you on out of that room and up to the postnatal ward. We want to give you some protected time as a family. So that's kind of a whistle-stop tour over physiology. I'm not sure if anybody had any particular questions about physiology of labour and what's happening, but hopefully that gives you a rough idea of how labour and birth develops. So a little look at questions. So that's a question about infant feeding, which I'll come to. And again about vaccines. So let me come down. So we'll answer the questions on physiology first, if that's all right. So Kerry, you said you've been experiencing irregular contractions today. How long does this last and when should you call MAU? You're 38 weeks today. So Kerry, every woman is different, and you will go from having those irregular contractions to having more regular ones. And when I mean regular, it is a bit like you can set your watch by them. You know, they tend to happen, you know, if it's, say, 3 minutes, that it's, or 3 minutes and 15 seconds, and it always happens at 3 minutes and 15 seconds. And you get that consistency. And if this is your first baby, then we say wait an hour or two of those regular contractions, happening 3 contractions in 10 minutes before you call in the midwife. If this is your second and subsequent baby, then because it is much quicker, we ask you when the contractions are coming every 5 minutes to contact wherever you're planning to give birth, whether the maternity assessment unit in community or the spires. So you've got a little bit of time, but you know, the really important thing, Kerry, just now is to make sure that you've eaten some nice complex carbohydrates, that you've drunk plenty of water, that you're going to the toilet to pass urine, and you know, like I said, if you feel like you can build in a nap, lie down and try and have a rest, that's good. So you've got a little bit of time, and it may be, Kerry, that things go off today and come back tomorrow, or they might go off for a bit, let you get some rest and come back again this evening. Everybody is completely different. But there is always a midwife at the end of the phone, either in the maternity assessment unit, the spires, if you want to go through, you know, how things are going and when you should contact them again. So Hayley, you've asked, are vaginal examinations a required part or they're optional? So Hayley, some women are actually choosing, are nagging us to have vaginal examinations because it's become the thing that people want to know. They want to know how they've progressed, and they aren't happy with us, you know, when we say actually we don't think one would offer any more insight. So we kind of use it as a, you know, we do everything in partnership with women, and it's very much about having the conversation with them. Some women come in earlier labour, and when we're feeling the contractions, we know that things are still an early stage, and we think actually you could do with a bit more time at home. And women are saying, please, can you examine me? And we try to say, look, we don't think it's necessary at this time. But obviously, if they want it, then after discussion, we would, you know, obviously agree to it. There has been some suggestion that we've been using it as a way to gauge whether it's the right time for partners to be here or not. You know, very much when you talk to our maternity assessment unit about what you do in terms of partners, they say it can be very clear from a phone call. It can be very clear from the phone call that actually this woman is in established labour and her partner comes straight in with her. For other women from the phone call, it's less clear. So in those situations, we'd say, come in without your partner and we'll see what's happening. But the see what's happening is not all about the VE, it's about us being able to see how you're coping. The contraction frequency, feeling those contractions, are one of the most important things to help us along the way. But vaginal examinations, of course, any examination that we do to you is optional, whether it's feeling your tummy to see if your baby moves, putting our hand on your tummy to feel your contractions, and everything can be declined. And not, we wouldn't, we don't see it as an aggressive thing. It's very much, anything that you do with another person that requires you putting your hands on them or in them is, of course, something that would require consent. So then we've got a post. We had a question about the mucus plug. When is the normal time to lose it? And when should birthing people be concerned to call in? How long can people expect to have between losing it and labour? Okay, so if I take you back to that cervix, excuse the hand, what's happening is your mucus plug is a blob of mucus that might have some blood in it that is sitting within your cervix. So if your cervix is starting to open and do things or make some changes, the mucus plug can get freed and come out. Now, if it comes out, lots of people have thought, oh, that's fantastic, that's my show, I'm going to go into labour. But actually, it just shows there's been some movement in your cervix, and I don't want to upset people, but actually a mucus plug can reform. The mucus can rebuild up again if there's no other change to the cervix, or it can continue to come away in waves, because as you'll notice in pregnancy, towards the end of pregnancy, you get a thicker discharge. So it can be sort of all related to that as well. So it's not, for us, a show. We have people phoning up and saying we have a show. Obviously, if they're having a show and they're less than 37 weeks pregnant, we do want to know about it. But if you're over 37 weeks pregnant, that just tells us that there's been some changes to the cervix and isn't actually something that would necessarily make us bring you in any earlier. Obviously, if you think that there's quite heavy blood as part of it, we do want to know about that. A little bit of blood is normal because the vessels all around your cervix are very fragile. So a little bit of bleeding as it starts to open is quite common. But any heavy, fresh red blood, we really should know about. And if at all you're concerned, then please let us know. So I hope that answers your question. Rachel, you said, does the syntocinon injection third stage have any negative impact on the baby or mother? You've been advised to have one as you have inflammatory bowel disease. Rachel, there isn't, the only risk associated with the giving the injection is that there's a slightly increased chance that that big contraction that happens to get your uterus to contract down does cause the cervix to close over as well, which means the placenta can get trapped inside your uterus. That's called a retained placenta. And to be able to get your placenta out, we have to take you to theatre to reopen the cervix to get the placenta to come out. It's a very, very low risk of happening with that drug, but they think the risk is slightly higher than if you did it physiologically. But you have to balance the issues that may come with not having it. So I think if your obstetrician has recommended it, then I do think it's probably a good idea to have it, Rachel. So Lisa, you've asked, when you're overdue, what is the reason that they will only let you go over 2 weeks? Does the baby just carry on growing? Yes, so Lisa, your baby does carry on growing. It puts down quite a bit of brown fat. So it bulks up a bit, but the main concern that we have going over 42 weeks is how well the placenta functions. So your placenta is basically the organ that is feeding your baby. It's providing your baby with the food and all the oxygen requirements and gas exchange that needs to happen. And like anything, it only has a shelf life of a period of time. And what they've looked at in terms of the evidence is that that shelf life for the placenta is much less after 42 weeks of pregnancy. So that's why we offer induction at 42 weeks, because we don't want you to be at increased risk of your placenta not working. And very sadly, it is associated with a stillbirth if your baby doesn't move. Now, we don't want to send people into lots of panic because actually the risk of stillbirth is low. It's just that when you look at the outcomes of pregnancies after 42 weeks, the rate of stillbirth does increase from before 42 weeks. So for us, it's a safety mechanism. We want a well mum and well baby at the end. So that's why our recommendation is 42 weeks. And that's for people under the age of 40. For women who are between 40 and 44, actually that risk gets bigger for them after 41 weeks. And for women who are over the age of 45, that risk gets bigger around 40 weeks. So each pregnancy, depending on different thing, has a rate limiting factor that means that actually their placenta is still working as well. In Oxford, we're unique. We have the 36-week scan, or we're certainly unique in our area. I'm sure there are other people that do it, but that is again looking at the shelf life of the placenta. It's not there to look at the size of your baby. It's very good at picking up small babies, but not so much bigger babies. But it is something that we look at. It's all about the placenta. Is it going to continue to work and do its job so that you have a well mum and baby at the end of it? So I hope that answers your question. Okay, so Katie, you were wondering what the chances are of having a shoulder dystocia again with your second baby, as seconds tend to be heavier. So Katie, if you didn't have a shoulder dystocia with your first baby, then the chance of you having it with your second baby is not increased. The only chance it increases is if you had it with your first baby, then there is a chance with your second baby. Now, some people have, and if you, a shoulder dystocia, for those of you that not sure of, it's a very rare thing to happen. But do you remember I said babies make those turns in your pelvis for their shoulders to be born after their head? For some babies, as they turn, their shoulder gets caught under the, at the front here. So generally it's their anterior shoulder, but when they go into the place where their shoulders are lying that way, they're making the turn, their shoulder gets stuck on the top bit here. Like I said, very, very rare complication, and something that we have various manoeuvres that we can do to help free baby's shoulder so that baby's born. So very low risk of happening. It happens more commonly in women who have diabetes that's been more difficult to control. So some women who are diabetic can control it very well with their diet or with some tablets, but if you start to increase and use insulin with diabetic women, that does increase its chance of happening. But we would very much have an individual discussion with people about that. But if you know, I think if you haven't had one before, just because you're going to have a bigger baby doesn't mean that there'll be a problem. And people do worry about having a big baby, especially the 36-week scan says it's big. Please be reassured that they tend to overestimate the size of bigger babies. It's easier to pick up littler babies. And actually, unless you have something like diabetes, you grow the right size of baby for you. So Joe, you're asking at what point of labour do you need antibiotics if you've group B strep? So Joe, we'd like you to have them when you're in labour, and ideally have them 2 hours, at least 2 hours before the baby's born. So it depends in terms of the length of your labour, if this is your first baby or your second baby. Sometimes with second babies, because they can happen really quickly, we don't always get the IV antibiotics in time, but we do everything we can to do that. And unless you have other risk factors, women who have group B strep can have their baby, if they're otherwise low risk, on the midwifery-led unit, on the spires, because we can give IV antibiotics here. It doesn't have to be delivery suite, just so that you have another option. Ellen, hello, at what moment is the injection made to help deliver the placenta? So Ellen, the best time to give it is as the baby is being born, or immediately after the baby's born, because it takes 2 to 3 minutes to work, to start working. So what the reason we're giving it is to try and reduce the chance of bleeding. So the earliest we can give it, the better. But clearly we don't want to give it if we don't think baby's about to be born. So anywhere from the baby's shoulder being born afterwards the baby. But the key advantage of having it is to minimise that blood loss at birth. So Vicky, your baby has been breech and transverse in the 3rd trimester. It's now head down. Fantastic. I'm 40 weeks today. Will the position be assessed on arrival at the hospital? Absolutely. Because Vicky, that what we call palpating your abdomen is one of the most important parts of our assessment. You know, we put our hands on your abdomen all the time during pregnancy to make sure we're happy baby's growing and moving properly and doing all the right things. Same thing in labour. When you come in, we want to feel how baby's lying and go from there. So brilliant, baby's head down. Sounds like it's a bit of a monkey in there, twisting and turning into different positions, but hopefully now in the right place to be born. But please don't be concerned. And if we're in any doubt when you come in labour, we have portable scans and we can check it. So Katie, not about labour, you've a scheduled caesarean section 2 weeks today and you wondered what's the plan currently when the partner can be there, what happens. Okay, so we will talk about caesarean section because I think that comes in with the discussion about partners that you wanted to have looking at the questions. So I'm going to hold that thought. Make sure if I don't answer it, Katie, we come back to it. I've fast forwarded that too much, Jade. Let's come back to your question. Your due date is tomorrow, but ended up with you guys in MAU over the weekend. Oh, so you had a bad urine infection. I'm sorry about that. And you're just saying, would I definitely know the difference in between the contractions and the urinary pain? Yeah, so you will notice the difference. The contractions come in waves. They're a bit like a hill, so they build up to the intenseness at the top and then they go away again. Urinary pain just tends to come on and stays on and isn't quite, is more constant pain rather than intermittent pain. And when you get the contraction pain, your tummy goes rock hard and it feels very, very tight inside as if everything's going to pop. So please, you will know the difference when it happens. But if you're unsure, that's what we're there for. We want to ask you questions and help you along the way. So Cheryl, you're 40 plus 5. You're hoping to have a vaginal birth after caesarean, and your contractions started today about 4 a.m. Really irregular. Then about midday you had a show. Less than an hour later, you wasn't sure if you'd leaked some amniotic fluid or if it's just more of the show. In your first labour, you got to 7 centimetres, then ended up with the caesarean section. A few contractions since, but still very irregular. So Cheryl, it sounds like your body's just getting warmed up. And what I should have touched on was the oxytocin. What we need to try and do, the reason why things like hypnobirthing and mindfulness work so well is because we need to try and help you to relax. And our instinct when we're in pain is to feel really tense and we get, really anxious about things and the pain, it kind of takes over our mind. And when that happens, you get a lot of adrenaline, which circles around your body. And that adrenaline suppresses your natural oxytocin, which is in your brain, which is a hormone that's produced which helps with contractions. So when we're inducing a labour, we use a synthetic form of oxytocin to bring on the contractions. So what we want to do is let the natural stuff happen. So we do say to people, massage works really well, aromatherapy, just trying to get in a positive frame of mind. Listen to some music that you like, whether it's loud, banging, heavy metal music or whether it's, dolphin sounds or anything else in between, but try to find that relaxation. Try to not worry about what's going to happen. Try to stay in that positive mind. And I always say to people, imagine in your head the kind of birth that you want to have, and that's what should be occupying your thoughts. Not worrying about what happened last time. Pop that away. Get in your headspace now for positivity around what's going to happen next. And I think that's really good sort of moving forward. So, make sure that you've eaten, drunk, rested if you need to rest. It will come back, it will come on. It's just your body getting ready for it. So share lots of love and positivity coming your way, lots of nice slow deep breathing, get a cuddle from somebody, get a massage if you can, but really getting into the right headspace now to have your baby would be fantastic. Joanna, if you need to go in and get assessed without your partner, generally speaking, how long would the assessment take? Are you seen straight away, or is there usually a wait? So, Joanna, we try to see you straight away. We've got a policy to try and see women in labour within 15 minutes of arrival into our maternity assessment unit. Obviously, if it's somewhere like the Spires or in the community, then, you know, once the midwife's there, sometimes people beat them to Wallingford or Cotswold maternity unit before the midwife's there, but there may be a healthcare assistant there. But it's very much, we try to get you seen within 15 minutes of being there. And then the assessment, you know, can take, you know, really a good half an hour to an hour to see what's happening and see what's going from there. But sometimes when women come in, it's blatantly obvious that they're in very established labour, and we just get you to call your partner straight in. But otherwise, if birth partners are waiting outside in the car, then, you know, generally half an hour to an hour before we'll know what's going on. Natalie, is there a possibility to still have a water birth if I'm consultant-led? Yeah, Natalie, it depends why you're consultant-led, but even for a lot of women, they can still use the birthing pool on delivery suite, even if it's not. Some women have risk factors that might make the second stage of labour be better to be on dry land, or the third stage of labour on dry land, but absolutely your midwife will have that conversation with you. If we have to do continuous monitoring of baby's heart rate, we do have wireless and waterproof monitors to enable that to be possible. Chloe, we've always in Oxford enabled people to have a water birth. You know, some organisations, you know, I was shocked to read lots of organisations around the country have stopped their home birth service and their water birth service, etc. But actually we've always still continued to run a full service. Rachel, you said, why would my obstetrician be talking about induction at 37 to 38 weeks if my baby has dropped further below her growth curve, sorry, I can't speak, at your 36-week scan? Is it not better that she keeps growing? So Rachel, what we do in terms of babies is we look at babies to ascertain whether it's better to continue growing inside or whether it's better to get babies out and grow them on the outside. So if they felt that your baby isn't quite getting what it should be from growing on the inside, it gets to a point when obstetricians say now would be the time for baby to come out, because actually it'll grow better once we get baby out. So it really is a safety aspect. I have to say, when you look at comparisons across the nationally, when we benchmark against other organisations, we have less intervention rates. Our induction rates are much lower than other units. Our cesarean section rate is much lower than other units, because we're trying to look at mum and baby and have them in the healthiest condition, and we don't want to interfere if we don't need to. So I think if your obstetrician is saying it's better for this baby to be born, then Rachel, it probably is better for the baby to be born. You can obviously decline, but it may be that will put baby at a little bit more risk. So, you know, have a good discussion with your obstetrician about the pros and cons bit. We're very into shared decision making in Oxford, and we want to make sure that you're happy with the decisions we make. Okay, so that's a question about scans. Okay, Katie, we'll talk about the risk of shoulder dystocia. I think it would be good for you to talk to your community midwife about it. But otherwise, if you privately message me, we'll go through that, because obviously it's looking at the whole picture. I don't know whether you had a shoulder dystocia because you had a forceps birth last time or what went on. So, you know, we can have a conversation about it afterwards. Evie, how can you tell what position your baby is in? I get what I think is a kick in my ribs, but feel like I can feel baby across my stomach and also pressure lower down. So Evie, I would go with where you feel the kicks and wriggles, because baby generally moves more with its feet. If baby has got its legs straight like that, you can feel kick and wriggles down here. And if baby's legs are bent, then you can feel kick and wriggles sort of up the top. But if you're not sure, please ask your midwife and she'll talk you through what she's feeling when she feels your tummy. So I think we're probably getting the end of the question. Joe, you want to know if you need to bring in a diffuser for aromatherapy. Joe, we do have them here on delivery suite and in the spires and our midwifery led units, but if you want your own, please feel free to bring it in. And I'm just so Katie, it sounds like you really want to birth your baby on the spires, but your BMI is a bit higher. Your midwife says you might be able to, as if you had a low risk pregnancy. How would BMI affect my chances on birthing in the spires? So Katie, do ask your midwife. If it is your first baby, you can birth your baby on the spires with a BMI up to 40. If it's your second baby, again, with a BMI up to 40 on the spires, the cut-off point in midwifery-led units for your first baby is around 35, but second babies is 40. If it's higher than that, please talk to your midwife, and if it doesn't meet criteria, then she would send you to talk to either myself or Emily, the other consultant midwife. Oh, I'm so glad, Yvonne, you had a positive experience. And I think Carla wants me to go back to her questions at the top. So well done for reminding me, Carla. Your baby is bottle fed and has reflux. Should be advised to change milk. When I change the milk, should I do that gradually or straight swap? So Carla, if you're changing milk, I think you just change the milk. Have you talked to the infant feeding team about it? It might be worth waiting and talking to them on Thursday when they're on at 2:30, because they may have more that they want to say. I'm just going to move into my office because it's telling me my battery's low, and the last thing I want to do is run out of battery today, so bear with me just a second while I plug in, and hopefully I'll not lose you in terms of signal. So hopefully you can still see me now. So I hope that answers your question. It's just some people think, oh, well, let's just change the milk, but actually there might be a feeding technique or something that may help. So that's why I suggested contacting the infant feeding team. In terms of the other questions that came up, Caris asked a question about the whooping cough vaccine. You get that at your GP surgery, so please contact them. I'm trying to think what other messages we had. I just wanted to make sure if you please post a question if I said that I'd answer something and I haven't. There's a couple of things that Maternity Voices Partnership asked me to raise. The first one being about face masks. So on 5 o'clock on Friday night, the lovely announcement came out about wearing face masks in hospital, and everybody has looked to us for a response and what that's going to mean for women in labour. We are not in the position that we are going to deny women using gas and air in terms of face masks in labour. That would be very difficult. I think labour and birth is a unique time and we have to think about it. In terms of what's happening with face masks, our trust, we don't get any warning that they're going to make these announcements, so we've not had much time to get our head around it either. So the trust are going to look at what is going to be required, and we will let you know as soon as we know, but at present we don't know what the requirement will be for hospitals. We are constantly revisiting everything that is happening and trying to work out a new normal. Now we're at the place that we're at in terms of COVID, and as soon as we have any changes, I promise we will share them with Maternity Voices to ensure that it gets out there, and we'll put them on our website. I've been asked continually about scan, and I do see some posts that come up every now and then about scan. I just want to reassure you that we are constantly revisiting this. We have detailed conversations about what we can do to make this a better experience for you, because we appreciate the absence of your partners can be more stressful for some people. We aren't in the position at present to change our scan pathway. It is under constant review. We had a meeting last week with the scan department about trying to reintroduce some scans that we had to stop doing for a period of time. So we're thrilled to be able to say that we've increased our scans, which means that we can still run our 36-week scan and all the other scans that we're doing. So I think, we're really proud of our scan department that they've continued to do as many scans as they're doing, and we don't want anything to influence that. So at present, we're staying with our same rules that partners can't be present for the scan. We're looking at other ways that we can help to make that a positive experience, but we don't have any changes as yet to announce to you. So unfortunately, and I know some of you may be disappointed, but for us it's much more important that we keep our scan department safe. There are obviously concerns that with the new trace and track system, that if we find that somebody has been exposed, it may mean that more staff members end up being off work, which will affect our scan provision. So we don't want to do anything at present that is going to influence the scans that we can currently offer. So I hope you understand. I'm really sorry if this makes people upset. The other thing I just wanted to share with you is that amongst these sessions that we've been doing, we have our Ask the Midwife line, which is available every day from 11 to 7. So please, if I haven't managed to answer your questions today, can you please call that line? Because there's a midwife sitting waiting for your phone call who's happy to answer the question for you. The other thing is we've run very successfully for years mindfulness in pregnancy courses. These are now online, and we have still got a few spaces for our online class that starts on the 1st of July. So they're held every Wednesday for 4 weeks, and they're between 6:30 and 8:30 p.m. And they, if you are interested in the course, please could you get in contact with Sian Warner. So that is SIAN for November .Warner, WARRINER @ouh.nhs.uk. So Sian would love to fill up some of the spaces on the course. They're a magnificent course to be part of, and they can really help. So please do sign up for those courses if you can. There are some more sessions I think people have suggested. They want us to run a home birth session, which absolutely we can do. But please bear in mind we've got films on our maternity website, the OUH intranet site. There's films on home birth, there's films on midwifery-led units, the tours and things are on there, as well as all of the films that you have on Oxfordshire Maternity Voices Partnership website. So I know I've overrun, I'm terribly sorry, I talk a lot, and I will be in touch with Maternity Voices to update them on information. There'll be some information coming out on antibody testing, some information coming out on the use of masks, and if there are any changes to any of our other visiting times or partners, etc., we will let you know as soon as possible. But at present we are still running exactly the same way. So in terms of, we've talked about women in labour and when partners join them. There was the woman, I'm sorry, I can't remember your name, who said she's having a caesarean section. Your partner comes in with you at the time that you have your planned caesarean section, and they stay with you when you go into theatre, when you come out of theatre, and after a couple of hours when you go up to the ward, your partner then goes home from there. So I hope that makes sense. I hope it answers all of your questions. And remember, please, the Ask the Midwife telephone line,
We feel it's very underutilised. I'm sure there's lots of questions out there, and it'd be much better if you could pose the questions there rather than during, our infant feeding session, for example, on Thursday. So thanks very much again. Stay safe, everyone, and hopefully it'll stop raining soon. And we will see you when you have your baby.